From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to this JAMA Clinical Reviews podcast. I'm your host, Dr. Karen Lasser, Professor of Medicine at Boston University and Senior Editor at JAMA. Today, I am joined by Dr. Erin Kelly, who is a researcher and Professor of Pediatrics at the University of Minnesota Medical School. Welcome, Dr. Kelly, to this JAMA podcast.
Thanks for having me, Dr. Lasser. I appreciate it.
It's a pleasure. So, to begin with, how common is adolescent obesity, and how has the epidemiology changed in recent years? What are some of the risk factors?
Right. So in terms of where we are right now, so in the United States, about 20% of adolescents ages 12 to 18 years old are living with obesity. And of course, we classify that based on body mass index, or BMI, at or above the 95th percentile for sex and age. And that number has generally increased since about the mid-1970s. When we talk about complications or comorbidities associated with obesity in adolescents, we think of things like prediabetes, insulin resistance, dyslipidemia. So we typically see things like low HDL cholesterol, high triglycerides, liver disease. We see musculoskeletal problems, and it's a highly inflammatory condition as well.
And how do things like screen time and food insecurity affect the epidemiology of adolescent obesity?
Well, what we're learning now based on the evidence, if we look at this from a higher level, what we're seeing is a convergence of an obesity promoting environment or society converging with biological predisposition. So while there's lots of discussion about things like screen time and access to physical activity, which are of course important, those are only two pieces to probably a 1,000-piece puzzle here. Obesity etiology is highly complex and multifactorial. It's caused by many, many, many things. But I think in general, there's an underestimation of the contribution of genetic predisposition or underlying biology, and an underappreciation about the forces that all of us are fighting against in the obesity promoting environment that make it very difficult to manage our weight properly, particularly over the long term.
And can you comment on the role of food insecurity?
Right. So we know food insecurity is part of this 1,000-piece puzzle. And we know that obesity tends to be more common in marginalized communities and people who have lower access to resources. And that would be including food. And so we know that the cheapest food tends to be the food that is processed, ultra processed. They have longer shelf lives. So these types of things make it, again, talking about this obesity promoting environment, make it difficult for individuals to engage in the type of activities and behaviors over the long term to manage their weight durably.
Thank you. Now, in healthcare settings, how should we be screening for adolescent obesity?
Right. So one of the things that we discuss in our review is the release of the American Academy of Pediatrics Clinical Practice Guideline. This is the first ever comprehensive guideline published by the AAP. And as part of that, they provide a one-page algorithm through the Institute of Healthy Childhood Weight that talks about evaluation of adolescents with overweight obesity. And of course, it starts with using body mass index as a screener. And we know that BMI is not perfect, but it is a very good starting point. And based on the level of that BMI, then there is guidance about other aspects that should be evaluated. And that would include screening for type 2 diabetes, for liver disease, and also for lipids.
So to summarize, clinicians should be screening for adolescent obesity with BMI. And would that be at every visit, or is there a certain interval?
The recommendation is to screen for BMI regularly, and this would be at least annually, ideally more often than that, because then the BMI and weight trajectories can be tracked over time. And of course, these are variable, and they are going to vary based on sex and age. And this allows the clinician then to track and have a conversation with the family about the direction that this is heading. And one of the things that came out of this AAP clinical practice guideline is that the era of watchful waiting needs to end. So this idea that adolescents will grow into their larger frame. What we're seeing with the evidence now is that obesity, excess adiposity, tracks very strongly from adolescence into later adulthood. So obesity is not a disease that spontaneously remits. And so the tracking of BMI and its associated complications and comorbidities is going to be very important so that we can identify things early and, deploy effective treatments.
Hmm. And how would you recommend that clinicians speak with adolescents about obesity, knowing it is a sensitive issue?
Very carefully and sensitively. So I think entering these conversations with an attitude of empathy and working to disarm parents, caregivers, and the adolescent patients. There's a lot of internalized stigma and shame that comes with obesity, unfortunately. So individuals feel this level of personal responsibility, like it's their fault. And in fact, one large international survey of adolescents living with obesity, one of the things that came out of that was that adolescents feel like it's their job and their job alone to manage their weight. And we know that really obesity management is a team sport, that it really needs to be done in a multidisciplinary fashion with all types of supports. And so this is important because, again, a lot of individuals sort of take this on as their own burden and that it's their fault. And again, back to this issue of this convergence of an obesity promoting environment with an underlying genetic predisposition. Really, the science is telling us that it's much more complicated than just, placing the burden on the individual.
Certainly. And what is considered first line treatment for adolescent obesity, and how effective is it?
That's a great question. So this is something that's changed just over the last few years. So back to this AAP clinical practice guideline, one of the interesting things that they talked about was that we need to get away from this stepped care approach that we've traditionally had for adolescent obesity. And by that is it used to be recommended that we would start with the lowest level, lowest risk interventions like lifestyle modification therapy, give that a trial and see how things would go. And then, if necessary, escalate and consider things like obesity medications and or metabolic and bariatric surgery. What we're hearing now, based on the evidence, is that based on the patient sitting in front of the clinician, decisions and discussions should be made based on tapping into the entire spectrum of comprehensive obesity care. So, for example, if you have an adolescent with a BMI that's up in the class 2 or class 3 level with weight related complications or comorbidities, the conversation should include the whole gamut of obesity treatment options. That would include lifestyle therapy, obesity medications, perhaps right out of the gate, and even discussions about metabolic and bariatric surgery. So we're getting away from this stepped care and getting more into tapping into all of the tools that are available right now, right from the get-go.
And when you mention class 2 and class 3 obesity, what BMI ranges are we talking about?
Right. So, how we classify 2 and 3 severe obesity is based on the 95th percentile cut point. And so, class 2 obesity we define that as 20% above that 95th percentile cut point. And class 3 obesity, 40% above that 95th percentile cut point. And we can also use absolute BMI as well. So for class 2 obesity, it would be a BMI at or above 35 kilograms per meter squared. And for class 3 obesity, a BMI of 40 or higher.
Thank you. Now, in terms of the newer anti obesity medications, how effective are they, and are there safety concerns?
Right. So this is one of the reasons why we thought it was the right time to write this review. Just in the last 5 years, we've had 3 new obesity medications that have been approved by the FDA for use in adolescents, from ages 12 to 18. So one of those is liraglutide. It belongs to the glucagon-like peptide 1 or GLP-1 receptor agonist class. There's another one, semaglutide, which is also part of the GLP-1 receptor agonist class. And then a third one has been approved as well, the combination of phentermine and topiramate, which is an oral medication. And when we talk about the effectiveness and safety, really many of us in this field feel like we are entering a new era because many of these medications are showing degrees of efficacy and effectiveness that far exceed what we've seen with earlier medications. So, for example, liraglutide in the large adolescent trial showed about a 4.5% placebo-subtracted BMI reduction with 1 year of treatment. Semaglutide showed about 17% placebo-subtracted BMI reduction with about a year to a year and a half of treatment. And then the medication, the combination of phentermine and topiramate, which comes in 2 different doses, showed a BMI reduction of about 8 to 10%. So now we're getting into the realm of what many of us who are in this field would deem to be clinically meaningful or clinically significant BMI reduction that is accompanied by, at least with some of these medications, improvements in things like cardiometabolic risk factors and quality of life, things that matter most to the patients and their families.
And one point you made strongly in your manuscript was that all of these trials, when they tested these medications, they also had a lifestyle management intervention as well, correct?
Correct. So, what we have seen so far, in I think virtually all of the medication trials, that there is a lifestyle therapy component. And this is a source of ongoing discussion in our field. What is the role of lifestyle modification or behavioral counseling in the context of the use of these anti-obesity medications? This is going to be a source of, I think, a lot of future research to try to understand how we ought to be delivering lifestyle therapy in that context, right? So if you think about how traditional lifestyle therapy has been and continues to be delivered, it talks about reducing portion sizes and tuning into internal cues about satiety. What we're finding with these new obesity medications is that because they work on these very pathways, these types of things are starting to be sensed naturally by the patient who's using the medication. So it may require us to fundamentally rethink how we deliver lifestyle therapy in the context of medications.
And can you go back to talking about liraglutide and semaglutide and comment on the side effects and how they can be managed by clinicians?
Right. So if we talk about the GLP-1 receptor agonists, this liraglutide and semaglutide, what we showed in the adolescent trials, first off, what we showed was the safety was very much aligned with the safety outcomes of the adult phase 3 trials of these medications. So the most commonly reported side effects in the trials were GI related, particularly nausea and vomiting that occurred early during the uptitration, the escalation portion of these medications. Most of the incidents in the trials were transient, so meaning that the individuals that experienced them, they tended to wane over time, but not fully. So if we look at liraglutide specifically in that adolescent trial, we saw about 10% of the adolescents assigned to liraglutide wanted to come off active liraglutide, mostly owing to GI side effects. So these medications, they do have side effects, and they're not appropriate necessarily for all patients. We saw a little bit lower of a withdrawal from therapy in the semaglutide trial due to GI side effects. So perhaps that semaglutide might be generally more well tolerated. But one thing that we're missing in terms of adverse effects are long-term outcomes. And this is something we talk about in our review, is that an area of future research needs to be long-term outcomes, not just of these new obesity medications, but all types of treatments and interventions in the whole spectrum of comprehensive obesity care, everything from lifestyle therapy to medications to bariatric surgery. Because we view obesity as a chronic disease that is going to require lifelong management, we really do need to see trials in interventions with longer term follow-ups.
Excellent. Now, which patients should consider surgery and how effective is surgery?
Right. So in adolescents, surgery far and away is the most effective and durable treatment for adolescent obesity. One caveat that I should say is that because of the nature of metabolic and bariatric surgery, most of the studies, most of the literature does not have comparative or control groups. They're not randomized. And so we need to have that in the back of our mind. But we do now have long-term data from the US. One of the largest cohorts is called the Teen Labs cohort. And there have been many publications showing the longer-term outcomes, 3, 5+ years. We're going to be seeing, I think, 10-year data in the not too distant future. But at 1 year, anyways, at least with surgery in adolescents, we see an average BMI reduction and weight reduction of about 30%. So when you compare that to the BMI reductions that I mentioned with the obesity medications, and certainly with the average BMI reduction with just lifestyle modification therapy alone, which is around 3% or so, you can see that bariatric surgery is much more effective. In terms of side effects, though, and adverse effects, it's surgery. So we know that there are perioperative risks. And when we think about, again, the long-term outcomes, we think about things like micronutrient deficiencies. There are two predominant types of bariatric surgery that are performed in the US on adolescents, the Roux-en-Y gastric bypass and the vertical sleeve gastrectomy. The latter, the sleeve gastrectomy, is the most commonly performed procedure in adolescents in the United States. That, compared to Roux-en-Y, appears to have a lower risk of long-term micronutrient deficiencies. We're going to need more data over time to confirm that, but it does seem to be a little bit better in that regard. And that's why I think we're seeing more uptake of the sleeve gastrectomy now as compared to the Roux-en-Y gastric bypass in adolescents.
Now, you touched on this a little bit before, but can you speak a little more about the health trajectory for adolescents with obesity?
Right. So this is where it gets into this in terms of a clinician and their decision making, the risk benefit balance. And we know all of these interventions that I mentioned come with potential risks. But we have to balance that against what we know are the long-term harms to human health that occur over time. And we really, in the literature now, have a lot of evidence to show that the long-term health trajectories can be pretty severe, especially when we talk about class 2 and class 3 obesity when that emerges in adolescents. So we think about big increases, large increases in the risk of cardiovascular mortality. We have seen data showing that the incidence of type 2 diabetes is much higher in adolescents living with obesity over time, incidence of certain types of cancers. And again, like I mentioned earlier, obesity tracks strongly. So this is not a disease that typically spontaneously remits. It's a chronic, lifelong disease that requires lifelong management.
Great, thank you. Now, is there anything else generalists should know about adolescent obesity that we haven't talked about?
Well, as we mentioned earlier, it's a highly sensitive area to talk about. It's fraught. And I think this can be intimidating for many clinicians, especially primary care clinicians who have a limited amount of time to potentially engage in these types of discussions. Again, I think the starting point is entering the situation with a sense of humility, sympathy, and empathy for the patients and their parents. One thing that we talk about a lot and that we see parents feel a lot of shame and judgment that they somehow may have caused this. And I think it's really, really important and incumbent upon clinicians to make sure to engage in conversations really carefully so that that isn't implied at all, that the judgment isn't implied at all, and that we now have tools and we're here to help. That's, I think, the hopeful thing. And something that was interwoven throughout our review was that we really entered this era of hope, not only for the clinicians, because there are tools available to help these teens living with obesity, but it's hope for the patients and the parents, right? As we inform them about the science that it's not their fault and we're here to help and we have tools that can potentially improve many aspects of their lives.
Absolutely. I'm Dr. Karen Lasser. I've been speaking today with Dr. Aaron Kelly from the University of Minnesota Medical School about adolescent obesity. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.